Hello. Thank you, Dr. Gaurav, for including me in this excellent course, and you can see from the attendance that it's very popular. The topic which has been allotted to me is extra procedures. At the outset, I'd like to say that I don't do too much of extra procedures. I'm a little more conservative when it comes to this particular procedure, but I think I'll probably start doing a little more after I've prepared this talk, because I've managed to read up a lot for it. So why is it extra? Because you're doing something more than your regular corneal refractive surgery. So essentially, when you're saying extra, it means that you're doing a corneal refractive surgery, which may be either a surface ablation or a LASIK or a SMILE, along with a simultaneous collagen cross-linking. And essentially, you're doing this because you have some sort of a borderline cornea. So why do we do it? Because we don't want ectasia. Basically, the bugbear of all corneal refractive surgeries is post-LASIK or post-iatrogenic ectasia. And you want to reduce the risk for that. And hopefully, because you're biomechanically strengthening the cornea along with the weakening that you're doing with your refractive procedure, you're kind of avoiding this risk. So essentially, we use it for borderline corneas, not just topographic, but even otherwise pachymetric or other biomechanical indices. And it is very important to understand that this is not a treatment for ectasia. So if you're thinking that this is early keratoconus, etc., this is a treatment for that, that's not extra. We do topographic guided treatments along with cross-linking for ectasias as well. But the cross-linking that is done there is different. It's a full fluence cross-linking. This is a partial fluence cross-linking. So we all know about the risk of ectasia, and we know that the LASIK is the one which has the highest risk, followed by SMILE, followed by surface ablation. And several studies have shown these risks, and we've also had case reports of ectasia after SMILE and surface ablation. So no procedure is completely safe from it. This is a very nice risk ectasia scoring system proposed by Bradley Randleman, which kind of told us what are the parameters one must look out for and kind of give a score. And based on that, you decide whether your patient has a low level or a moderate level and high risk score. People also been looking at the percentage of tissue alteration to avoid the risk of ectasia. So this was a nice paper which came in the IGO from Dr. Sri Ganesh's group, in which they've come up with a very nice simple algorithm to decide which are the patients which possibly could be cases for an extra procedure. So of course, you look at all the parameters that you need to look at preoperatively for any refractive procedure, and if all are absolutely within normal range, please go ahead and do what you normally do. But if you have anything which is borderline, this may be a possible option, other than, of course, not doing anything or wearing contacts or going for a phakic IOL if suitable. So what they concluded from this review of literature of various extra procedures for both all three, PRK, SMILE and LASIK, was that it's generally safe and effective, which means that it doesn't alter the refractive error too much, and it doesn't cause too many complications. But because most of these studies had very short follow-up, we don't have long-term data. And that's really a very important point, because we know that post-LASIK ectasia can come even years after the procedure. So we probably need long-term studies, and which hopefully should come soon. And then we will be really in a position to say whether these extra procedures really help us or not, or are we just charging our patients more and making it more expensive for them. Also, there's a lot of confusion about which settings to use, what riboflavin to use. So everybody's done their own thing, and that is why it's very difficult to draw any good conclusions from the data. So this was one of the long-term studies from the summary of the different long-term studies for PRK Xtra, and you can see that the number of eyes is fairly good, 40, 47, 98, 109, etc. But the follow-up, only one study has 25 months, all the others are 1 year or lesser. And what they've shown is essentially the refractive results are quite good, as you can see in that bar. And most of them are within 0.5 of expected results, which is what we want. Corneal haze does happen, but not a very significant haze. So that's something which one must certainly watch out for. LASIK Xtra, there have been various studies. In fact, this was probably the first Xtra procedure, especially Tomita et al. Had a very, very large series from Japan. And essentially, they've shown equally good results as LASIK, in some cases even better. And they've not had too many complications. So this is one subset which had good efficacy, but safety, again, we need long-term data to see if, because we know post-LASIK ectasia can take time. And LASIK is the weakest of all the refractive procedures. So whether it stands the test of time is something we need to wait and watch. Smile Xtra is the newer kid on the block. And some of the bigger data has come from Dr. Sri Ganesh's group from Bangalore. And they again seem to be showing that it seems to be very effective as well as fairly safe. So how is the protocol any different? Basically, when you're doing a PRK Xtra, it's always better to do a transepithelial ablation, because you can also, you could do that, or you could do an alcohol assisted. Transepithelial is preferable. Riboflavin to use, there's a lot of confusion, but most of the people are using riboflavin with HPMC. Some people have also used with saline. Depending on which riboflavin you're using, the soaking time can range from 90 seconds to 15 minutes. UVA irradiation is 30 milliwatts per second for 90 seconds, or 9 milliwatts for 10 minutes. So again, variable depending on different groups have used different things. Mitomycin C, there's a lot of confusion whether one should use or not. There is no clear answer. I don't really think it helps so much to reduce the haze in these cases. In general, the risk of haze is a little higher. LASIK Xtra, this is what we do. Basically, you create your LASIK flap either with a femtosecond laser or a microkeratome. Then you soak with the riboflavin, which is containing saline, not dextran or HPMC. And this basically soaks the stroma very rapidly. So you just need a few seconds, about 90 seconds of exposure. And then you wash this, and then you kind of put the flap back, and then you essentially do the cross-linking. Now, in the disadvantage of both LASIK and Smile Xtra is that you have epithelium on top. And because of that, possibly your penetration of UV may not be as good. Also, the availability of oxygen at the site of cross-linking may not be as good. But again, these are not ectatic eyes. These are normal eyes. You're just giving them a little more. So you create the flap. Then I told you all this. Basically, again, you use riboflavin saline, and the fluence is variable. Different people have used different things from 1.4 to 5.4. So from very low fluence to a full fluence. Smile Xtra, again, this video I borrowed from Dr. Luthra. You do your routine procedure, and after you remove the lenticule, you essentially put riboflavin containing saline in the interface, and you soak it for about 90 seconds, and then you wash it, and then you do the UV exposure as usual. So again, here people are using a partial fluence kind of a protocol, which is 3.4 joules per centimeter square. So the verdict is out there. We don't really know whether it's 100% needed, but it seems to be fairly effective and safe in terms of not altering the refractive outcome and not causing too many complications. What are the cons? You do have a risk of refractive shift, although studies have shown that it's not significant. Haze has been there in all of them, except LASIK has not shown too much of haze. And because of that, you may have a reduced wow effect. Also, because the increased time, patient may not be very happy with it. Also, you're increasing the cost for the patient, which has to be kept in mind at all times. The main drawback, like I mentioned, is the lack of long-term data, and standardization of protocols is something which needs to be done, because everybody has been using different types of riboflavin, different fluence protocols. So we need more data, and I think that this is one place where big data might come to our aid. Thank you.
Thanks, Rishi, for that. Nice. So, touching almost all the Xtra procedures, and then We have, Shri Ganesh here, who's, specializes in Smile Xtra, procedures. And I've been using a lot of Smile Xtra as well. And we've also seen occasional haze following Smile Xtra, which I think is. So I wanted to ask you about your topical steroid protocol. And Rishi, you for your PRK Extra steroid protocol, do you change it for your procedures? And Shri can tell about Smile Xtra.
There are few things to avoid haze. One is that you need to wash out the dye thoroughly. If after putting in the riboflavin, and the type of riboflavin you use, 0.25% isotonic. So don't use anything else. Otherwise, again, if you use riboflavin with dextran, you'll get severe haze. So that's something that you should avoid. Isotonic, 0.25%, soak for about a minute or two, and then the UV at about 3.6 joules. That is one thing. Wash out the dye thoroughly. The second thing is we put them on steroids for about a month, and then later on, if there is any haze, then we change over to fluorometholone and then continue it for maybe another month or two. The third aspect is that you will have to tell your patients to wear UV protection glasses for 3 to 4 months after the extra procedure, because if they go out in strong sunlight, then this also increases the risk of haze. Usually what we see is the haze is mild. We have also, it does not affect visual acuity. We have done the OSIs to see if it worsens the scatter. It worsens scatter slightly, but not very much. So we don't get severe haze. It's not haze that reduces quality of vision or affects visual acuity, but nevertheless you can see it. It is mild, which shows that the procedure is acting. So it's okay. But if you're getting more than that, then probably you need to look at these things.
So which steroid for the first month, and is it different from your usual Smile?
Prednisolone acetate.
And for your usual Smiles, what do you use?
Prednisolone acetate.
Okay. So, and usually you put them for how many days, like in your normal procedures?
We taper them. Start with 4 times a day, and then 3 to.
No, for your regular Smile.
Regular Smiles.
Okay.
Even for
even with Smile Xtra,
Extra, I use
because we use only FML for our Smile patients, and
no.
that too for just a week.
No, even for Smile Extra, we do FML only, but we use it for a longer duration than we would do for Smile. And I think if you wash it off thoroughly, I don't necessarily think we have to use Predfort kind of potent steroid drops, because I have not had a single case of haze.
We looked at using Lotopred instead of prednisolone. But somehow the quality of vision immediately after Smile when you use Lotopred is less. Okay. Because we had a few steroid responders. These young myopic patients, higher myopes, they are steroid responders, and we have had patients who have come in with steroid response, even early steroid response, and had blurring of vision.
So then why would you use high potency drops for
because see, what we do is we we call them on the 3rd day and after 1 week now and check the IOP. Okay, so you have the pre-op baseline IOP. Whatever IOP you check post-op has to be less than pre-op. Suppose pre-op they have a 14 millimeters IOP. Yeah. Post-op has to be less than 14. If it is 18, that means there's a steroid response. Yes. 18 is normal, but don't send them home.
True.
Because they are getting a steroid, immediately kind of shift or stop.
And it's not uncommon to find steroid response. We find
so many. The argument came up because you said for Smile Extra you use high potent drops. I said it's not needed.
That's the reason why we shifted to Lotopred. But what we saw with Lotoflam is that the quality of vision and the visual recovery is less than if you use Predacetate. So we went back to Predacetate. Patient satisfaction is much better when you use Predacetate in terms of quality of vision, recovery of visual acuity. We have many of our patients having excellent. We just shifted to see if this is. So now what we do is our protocol is call them early, look for steroid response. If there is a steroid response, then immediately we put them on anti-glaucoma medications and kind of. So that's our protocol.
Perfect. Thanks. And Rishi, quick one on PRK.
So for me, it's the same as the regular PRK, which is slow taper of surface steroids over 3 months.
Great.
Yeah.
Great. Thanks.